Welcome to Year 2, Module 4 of the My Mind Zero Suicide Trainings. I'm Leslie Johnson, and my pronouns are she, hers, and hers. This training, like the last one, will focus on populations of patients who are at particular risk for suicide. While we want to be aware of the risk of suicide for all patients under our care, we know that there are certain populations of patients who are at increased risk. For this reason, we focused once again on a few specific populations for today's training. Before we get started, I just need to say that support for My Mind is provided by Blue Cross Blue Shield as part of the BCBSM Value Partnerships Program. Although BCBSM and My Mind work collaboratively, the opinions, beliefs, and viewpoints expressed in this training do not necessarily reflect the opinions, beliefs, and viewpoints of BCBSM or any of its employees. Here is our meeting agenda for today. We'll talk about several health conditions, starting with the relationship between substance use disorder and suicide, then review chronic pain and how it increases suicide risk. Then we'll discuss the suicide risk as it relates to traumatic brain injuries and sleep disorders, and we'll wrap up by briefly discussing the effect of multiple health conditions on suicide risk. We'll have case studies just like we did in the last module. We'll begin our discussion with substance use disorder and how those who experience it are at higher risk for suicide. To give you some idea of the magnitude of substance use disorder, or SUD, here are some statistics from SAMHSA, the Substance Abuse and Mental Health Services Administration. In 2024, 48.4 million people aged 12 or older in the United States had a substance use disorder in the past year. That's nearly 17% of the population. Now to discuss SUD as it relates to suicide risk. One study showed that up to 40% of patients seeking treatment for SUD report a history of suicide attempts. They also found that the risk was particularly high for women. Studies have also shown that women may be reluctant to enter care for SUD and may have a more severe condition when they do seek care for it. The study found that people entering substance use treatment face elevated suicide risk because they often arrive with depression and major stressors like relationship loss, unemployment, and financial or health problems. These factors both drive treatment seeking and increase vulnerability to suicidal behavior. This shows that suicide risk must be assessed and addressed alongside addiction, and that many patients also experience social determinants of health stressors that further heighten their risk. While all substances raise the risk for suicide, I'm going to focus for a moment on opiates and suicide risk. Patients with SUD in general are at a risk level of suicide that is 10 to 14 times higher than in the general population. And those who have opiate use disorder and alcohol use disorder are at the highest risk. Combined with high overdose deaths and data showing that patients with opiate use disorder are not routinely screened for suicide risk, this highlights the need for consistent screening. These risks may also be underestimated since intent is often unclear in overdose deaths, and some patients avoid disclosing suicidal thoughts due to stigma or fear of hospitalization. Now I'm going to focus on alcohol. Alcohol is legal, readily acceptable, and socially acceptable. This can make it difficult to avoid. Furthermore, intoxication can increase the possibility of a suicide attempt in people who experience alcohol dependence, as well as in those who do not. So even alcohol misuse without dependence raises suicide risk. One study showed the reasons that someone who is intoxicated may attempt suicide. They are increased distress, increased aggressiveness, increased impulsivity and decreased regulation, and impaired cognition that would prevent them from choosing other coping strategies. One thing that makes alcohol such a risk factor is that it lowers inhibitions. And people with lowered inhibitions are more likely to be impulsive. And since impulsivity is also a risk factor for suicide, it makes it all the more important to talk to your patients to make sure that they understand these risk factors. This study also listed other risk factors for suicide in people experiencing alcohol use disorder. The greatest risk factor for suicide or a severe attempt is having a diagnosis of major depression. Other risk factors are included on the slide, such as acute stressors like relationship disruption, unemployment, and serious medical problems. Another study showed that substance use disorders are associated with suicide even after adjusting for other factors that are known to increase suicide risk, like psychiatric conditions or physical health status. And all categories of SUD are associated with significantly increased risk of suicide for both men and women. Finally, they found that having multiple substance use disorders was associated with a significantly greater risk of suicide mortality than any of the individual SUD categories. This underscores the importance of assessing your patients who suffer from SUD for suicide risk and encouraging these patients to get into treatment. A subject matter expert shared that over her 15 years in the field, she has seen people entering treatment with increasingly advanced disease. She noted one hopeful point. While sobriety reduces suicide risk, simply entering substance use treatment also increases protective factors. This highlights the importance of getting people into treatment as early as possible. The study from the last slide reiterated the importance of screening for suicide risk in patients who suffer from SUD. This should include suicide risk screening at the time of admission to substance use treatment programs, as well as continued screening for risk while in treatment. It is also important to screen patients with SUD in areas where the patient might not be looking for treatment for the disorder, but may be there for other complaints. Our content experts noted that it's important to be aware of the relationship between trauma, adverse childhood events, and SUD. Some people use substances to forget the pain of the trauma that they experienced. So when you know that you have a patient who suffered from trauma in their life, remember to screen them for substance use. If they do suffer from SUD, you can encourage them to get treatment for that as well as the trauma. I've included here a couple of SUD screening tools. The Audit C screens for alcohol misuse, and the DAST-10 is for inappropriate drug use. It's important that we treat both substance use and suicide risk to give our patients the best chance of recovery. We must treat the whole person to help them reach recovery from substance use and suicidal thoughts. Common treatments for SUD are pharmacotherapy, support groups like Alcoholics Anonymous, Narcotics Anonymous, and Smart Recovery, and therapy. Psychotherapy can include treatment for both SUD and underlying conditions, as well as relapse prevention. Motivational interviewing is another useful tool for primary care and behavioral health when treating patients with suicidal ideation and substance use disorder. It began in substance use treatment and is now widely used across many behavior change areas, including suicide prevention. A motivational interviewing expert noted that ambivalence is common in both substance use and suicidal thoughts. Recognizing this ambivalence and giving patients space to discuss it, as well as their goals and values, can help them identify what keeps them alive or motivates change. For example, if somebody values being a reliable worker, but their substance use conflicts with that, it can be a productive starting point. They emphasized that providers' priorities often differ from those of their patients, which can make collaboration harder. Allowing patients to talk through their ambivalence is often more effective than pushing change. Many patients already know what they need to do for their health, they just need time to get there. Here is the suicide prevention care pathway for behavioral health again, showing the relative suicide risk for different conditions. Just like in the last training, I'll be highlighting the conditions that I discuss and their relative suicide risk. When you have a patient who's experiencing SUD, it's important to remember their relative suicide risk. Current intoxication with alcohol or any substance abuse within the last month puts a patient at high risk for suicide. Drug use disorder within the last 5 years or opiate abuse within the last year puts a patient at moderate risk for suicide. And remember that impulsivity also puts a patient at moderate risk for suicide, and intoxication increases impulsivity. This is why it's so important to be aware of the elevated risk of suicide for our patients who are experiencing substance use disorders and what risk modification steps we can take. On the next 2 slides, I've shared some resources that can be shared with patients who experience substance use disorders. I'll be sending out the slide deck after the training so that you can have this information. On this page, you'll see some more resources for patients who experience SUD and their loved ones. There are many resources available to patients who are experiencing substance use disorder, and as discussed in previous modules, it's important that we provide patients with access to community resources to help them manage all behavioral health symptoms, whether that's suicidal thoughts or substance use disorders. Here we have Aaron, and he's a 22-year-old male who is seeing you for required vaccinations for his college sports team. Aaron has a history of binge drinking over the last 3 months. He also admits to smoking marijuana about 5 times weekly. He has one brother that he's close to and several friends. His friends and his family have noticed his drinking and smoking, and they've expressed concern. He scored a 1 on question 9 of the PHQ-9 and 8 overall. He does admit to experiencing anxiety related to the pressure of school and sports, and he says that he drinks and or uses to relieve the anxiety. Let's think about Aaron and what you might do for a patient in his situation. So, what are Aaron's risk factors for suicide? What are his protective factors? In addition to suicide risk, what will be important issues to address with Aaron? What interventions should you consider for Aaron's suicide risk? And what services should be looked into for Aaron's other concerns? Next, we're going to discuss chronic pain and suicide risk. A chronic pain expert noted that some patients lose the ability to enjoy life and lose hope for improvement, factors that place them at higher suicide risk. It's not just reduced pleasure, but the loss of enjoyment in things that they once valued. With this in mind, we can focus on how to support these patients and help reduce their suicide risk. Let's look at what chronic pain is and its prevalence in the United States. A general definition of chronic pain is pain on most days or every day during the previous 3 months. Another type of chronic pain, high impact chronic pain, is chronic pain that also limits daily life or work activities on most days or every day during the previous 3 months. In 2023, an estimated 24.3% of US adults, or 60 million people, had chronic pain, and 8.5%, or 21 million people, had high impact chronic pain. According to the U.S. Pain Foundation, pain is the number one reason that Americans access the healthcare system, and chronic pain is the leading cause of long-term disability in the United States. And more than 14 million people who have high-impact chronic pain are unable to work. Chronic pain is associated with reduced quality of life as well as an increased risk of anxiety and depression. Even after accounting for mental health disorders and comorbidities, chronic pain remains a significant risk factor for suicide. So it's important to screen your chronic pain of your patients who experience chronic pain for suicide risk. One of our content experts described it in this way. Many patients who suffer from chronic pain shared that they don't want to die, but they can't feel better. This is where thoughts of hopelessness can come in, which we know is another risk factor for suicide. Two concepts that you may run into in the literature are those of mental defeat and pain catastrophizing. Mental defeat is characterized by the perceived loss of autonomy due to uncontrollable traumatic events, resulting in the person giving up efforts to retain identity and self-will. Pain catastrophizing is characterized by the tendency to magnify the threat value of pain stimulus and to feel helpless in the context of the pain, and by a relative inability to inhibit pain-related thoughts in anticipation of, during, or following a painful encounter. A subject matter expert emphasized helping patients shift their goal from eliminating pain to managing it. Exploring their values can also reduce feelings of uselessness, especially when pain limits work or daily activities. Values exercises help patients identify what matters to them and how they still contribute to loved ones, which can reduce pain catastrophizing and feelings of defeat. Data suggest a lifetime prevalence for suicide attempts of between 5 and 14% for patients experiencing chronic pain, and a suicide rate that is 2 to 3 times greater than that of the general population. One study found that conditions like insomnia are risk factors for suicide in the chronic pain population. Some of these conditions, like headaches, are commonly seen in the primary care clinic. It's important to keep the suicide risk of these patients in mind and screen them using a validated instrument like the PHQ-9. Our co-director, Dr. Ramadani, also emphasizes the connection between chronic pain and sleep disturbances. This co-occurrence exponentially increases suicide risk. It's also important to know, as we'll see in a few slides, that multiple comorbidities, even without the presence of pain, put a patient at elevated risk for suicide. As you can see, chronic severe pain puts a patient at moderate risk for suicide with no other risk factors present. This underscores the importance of screening your patients who are experiencing chronic pain for suicide risk. Conversations about pain can be tough because the patient can interpret the provider thinking their pain isn't real, so the provider needs to validate their experience. If primary care is referring a patient who has chronic pain to behavioral health, they need to be clear that behavioral health can help a patient with the emotional effects of chronic pain and help the patient with ideas and techniques to cope with the pain and lessen its effect on the patient to give them a better quality of life. Another expert stressed that real progress isn't possible unless we take the patient's pain seriously. Managing chronic pain is exhausting, and patients often feel they must convince others that their pain is real, especially because they don't look sick. As sympathetic clinicians, it's important to recognize these past experiences and validate their pain and offer hope when they need it most. A multidisciplinary approach is also shown to help reduce risk for suicide and improve outcomes for patients experiencing chronic pain and suicidal ideation. In conclusion, our experts said that the three most important things in addressing chronic pain in a patient are validate the patient's experience, address the catastrophic thinking, and CBT is a therapy that can be very effective in addressing this, and reactivating. Patients who experience chronic pain often don't move much because of the pain, but this makes the pain worse in the long run. Using tools like behavioral activation in behavioral health care is important to get patients moving in incremental ways so that they can build up their stamina and begin participating in activities they enjoy again. Here I've included some information on the U.S. Pain Foundation as well as two programs that they support. And here I've put information on the American Chronic Pain Association, which has patient resources and support groups, and Chronic Pain Anonymous, which has face-to-face, virtual, and phone meetings. Here we have Zach, and Zach is a 56-year-old married male. He and his wife are active in the local church, and his faith is very important to him. He has a remote history of a motorcycle accident in which he sustained bilateral arm fractures, left tibia fibula fracture, and L1 to L3 fractures with fusion. He has developed significant arthritis in these areas. He's in your office for a new patient appointment and scored a 2 on question 9 of the PHQ-9 and 11 overall. He says that he's in constant pain from his old injuries and doesn't know what to do. He says the pain regularly wakens him from sleep and he doesn't remember the last time he had a good night's sleep. So let's think about Zach and his situation. What are Zach's risk and protective factors for suicide? In addition to suicide risk, what will important issues be to address with Zach? What interventions should you consider for Zach's suicide risk? And what services should be investigated for Zach's other concerns? Patients with multiple chronic conditions were also at significantly increased risk for suicide. And several conditions like back pain, sleep disorders, and traumatic brain injury were all associated with suicide risk and are commonly diagnosed, making patients with these conditions primary targets for suicide prevention. Well, we hope to review more of these conditions in future trainings. For today, we'll focus on sleep disorders and traumatic brain injury and briefly on multiple health conditions. First, we'll discuss traumatic brain injury and the risk for suicide. According to the Brain Injury Association of America, there are more than 5.3 million individuals in the United States who are living with a permanent brain injury-related disability. That's one in every 60 people. At least 2.8 million Americans sustain traumatic brain injuries in the United States every year. While we might think of TBIs in the context of car accidents and similar events involving trauma, it's important to remember other ways that a patient can sustain a TBI, like young people playing sports or survivors of domestic violence. And as I discuss TBI, I want to make clear that I'm talking about moderate to severe TBI. Mild TBI, like a mild concussion, doesn't carry the same risks. At baseline, people with TBI already experience higher rates of psychological distress than others. One study found that the overall prevalence of depression is 38% in people with TBI, 3.41 times greater than in controls without a TBI. It also found that clinically significant anxiety is present in 37% of people with a TBI. One content expert that we spoke to, who has worked in the field for 30 years, indicated that emotional lability and irritability are also common in patients who experience TBI. Depression was a strong, independent predictor of suicidal ideation for patients who experienced a TBI, confirming the importance of detection and need for effective depression prevention and treatment after a TBI. One study documented that fewer than half of individuals with self-reported depression in the first year following a TBI received depression treatment. This is where the care pathway can come into play. Primary care providers who have patients who experienced a TBI should always consider what risk modification steps that they can take and what referrals they can place to ensure the patient receives a full suicide risk assessment and necessary treatment. According to another study, suicide risk after TBI is 3 to 5 times greater than in the general population and is often associated with cognitive, physical, emotional, and behavioral impairments. Also, after someone has had a TBI, so suicidal ideation is associated with a 5-fold increase in the probability of a suicide attempt. Another study found that depression, anxiety, and substance use were associated with suicide risk after TBI. Depression symptoms were associated with increased suicide risk in the study, which is consistent with the association being found in individuals without TBI. One study emphasized the importance of addressing suicidal ideation and depression in patients with TBI. It indicated that, in agreement with other studies, interventions aimed at functional impairment early in the recovery process from TBI are associated with an improved mood in those who experience TBI. This study also emphasized the importance of assessing those with TBI for suicidal risk and suggests adding screening for suicidal ideation to the normal clinic flow. Finally, the study suggests that if suicidal ideation is a concern, that it should be addressed directly as opposed to indirectly through rehabilitation. Here we have the risk stratification from the care pathway again, showing that TBI within the last year puts a patient at moderate risk for suicide without the presence of other risk factors. The VA recommends several interventions for patients with TBI, including physical, occupational, and speech therapy, assistive technologies, strategies for managing cognitive, behavioral, and health challenges, and medications. CBT is also helpful for patients with TBI, and it remains essential to screen for suicide risk. While some interventions, like assistive technologies, may be less common in primary care or behavioral health, we wanted to highlight the range of available treatments. Since you're more likely to see patients with a mild TBI, like a concussion, I've included CDC discharge instructions for your reference. The content expert that we spoke to emphasized that function after a TBI is often predicted by pre-injury function, and many people can return to normal or near normal functioning after their injury. She also said that there are treatment modalities that work for people with a TBI, just as they work for people without one. These include cognitive behavioral therapy and acceptance and commitment therapy. Here are some resources for people who have experienced TBI caregivers, and providers. Now we have Faye, and she's a 32-year-old female who is a service member in the Army. On her most recent deployment 6 months ago, she sustained a moderate TBI. She was hospitalized at the VA and spent a month in their rehabilitation center. She remains close with several other service members who visited her regularly in the rehabilitation center and who remain in touch with her. While she's made significant improvements and has developed some coping skills, she still experiences emotional lability and short-term memory loss. She's in your office for a return visit. She scored a 2 on question 9 of the PHQ-9 and 18 overall. So let's think about Faye. What are Faye's risks and protective factors? What interventions should you consider for Faye's suicide risk? What other factors are important to address with Faye? And what services should be looked into for Faye's other concerns? Now we're going to talk about sleep disorders. Lack of sleep has a clear negative impact on mental health and daily functioning. And for people with sleep disorders, these effects are even more severe. Research shows that even one night of poor sleep can lead to mood changes, reduced executive functioning, and memory problems. Chronic sleep disturbances are linked to higher risk for depression, bipolar disorder, anxiety, and increasingly suicide. According to the CDC, in 2020, 14.5% of adults had trouble falling asleep most days or every day in the past 30 days. The percentage of adults who had trouble falling asleep decreased with increasing age from 15.5% among adults aged 18 to 44 and to 12.1% among those aged 65 and older. And women were more likely to have more trouble falling asleep than men. Here we have the risk stratification again, showing that global insomnia puts a patient at high risk for suicide without the presence of other risk factors. But as you'll see, global insomnia is not the only sleep disorder that elevates the suicide risk for your patients. One study indicated that insomnia, both as a symptom of depression and as an independent problem, was associated with suicide. They further found that sleep disturbances are reported by up to 92% of individuals who attempted suicide. This is a staggering number of individuals, and it highlights how important it is for us to be aware of how sleep impacts suicide risk. The same study found that insomnia symptoms were also found to predict suicidal ideation and suicide attempts independently of depressive symptoms and hopelessness in young adults. One study found that sleep disorders have been identified as independent risk factors for suicidal ideation as well as suicide attempts. The same study showed that 38% of patients with restless leg syndrome in the sample endorsed thoughts of suicide, with patients experiencing depression and restless leg syndrome being more likely than controls to attribute their sleep disturbances, depressive symptoms, and suicidal ideation entirely to restless leg syndrome. Another study indicated that the presence of restless leg syndrome was associated with significant increase in severe depression. And as we know, severe depression puts patients at a high risk level for suicide per the Zero Suicide Guidelines. One study showed that between 39 and 61% of patients diagnosed with obstructive sleep apnea have insomnia symptoms. As we know, insomnia puts a patient at elevated risk for suicide. A large study found that sleep apnea raised the risk of both suicide and self-harm. The results suggest that patients diagnosed with obstructive sleep apnea have a moderately increased risk of suicide and deliberate self-harm when compared to those without that diagnosis. The sleep expert that we spoke to said that she worked with a lot of patients who have sleep apnea, and about half of patients experiencing sleep apnea have insomnia. She said that the good thing about sleep apnea is that it is treatable, and that gives patients hope. CBTI is the main treatment for sleep problems. Our expert starts with CBTI and tailors additional strategies to each patient's values and priorities. A key part of care is correcting misconceptions about sleep and helping patients understand normal sleep changes over time. She also emphasizes instilling hope, acknowledging the effort that it takes just to show up, gently challenging any hopelessness, and using tools like safety plans or values exercises. This slide contains some resources for sleep. Now we're going to discuss the prevalence of suicide risk among patients with multiple health conditions. Here you can see that having multiple chronic medical problems raises the risk for suicide. And as we'll see, suicide risk is significant for several conditions. And remember that 83% of people who died by suicide saw a healthcare provider in the weeks and months before their death. We can prevent that from happening by screening every patient every time for suicide risk. Research shows that patients who have multiple health conditions are at greater risk for suicide. One study showed robust association between 17 health conditions and suicide. 9 conditions had a robust association with suicide even after adjusting for mental health and substance use disorder diagnoses. Nearly 62% of people who died by suicide had at least one of these conditions, and only 36% of the control group had these conditions. The next slide will show which of these conditions were associated with suicide. There are 17 conditions associated with suicide. Conditions associated with suicide after adjusting for mental health conditions include back pain, brain injury, cancer, CHF, COPD, epilepsy, HIV/AIDS, migraine, and sleep disorders. I know there was a lot of content that we covered today, and I really hope you found today's information helpful. The key takeaways for these conditions and reducing suicide risk are always treat the underlying condition. If in many, if not all of these conditions, a multidisciplinary approach is needed. Risk modification is important. Remember to modify the risk both of the condition and of suicide. And for all these conditions, instilling hope is particularly important. Here are our references. Here are a couple of resources for anybody who might be interested in motivational interviewing. And remember, if you're experiencing emotional stress or thoughts of suicide and need support, you can call or text 988. When we're caring for others, it's easy to forget that we can be struggling ourselves. So remember to check in with yourself and access resources for yourself if you need them. Let's take a moment to celebrate the fact that you've just completed year 2 of the My Mind training. We're so grateful to have you engaged in this program and honored to work with you as you strive for the goal of zero suicide. I hope that you take some time today to celebrate yourselves and your clinics for all the lives that you've impacted in a positive way. As I'm wrapping up today, I also wanted to remind you that PDSAs are due on May 1st. If you need a refresher on PDSAs, check out the slide deck for the Year 2 Module 1 training, Leveraging QI to Mitigate Suicide Risk, on the My Mind Partner portal, or reach out to me anytime with questions. And remember that we're holding office hours. The goal is for all of us to be working to improve our processes around zero suicide work, and PDSAs are an important part of that goal. You can always reach me at the email here if you think of any questions. Thank you again for talking through these patient populations. Have a great day, and thank you for attending the My Mind Year 2 training, Special Populations Part 2.